Please share from YouTube. Let your friends join. Now we have just a minute.
Oh, 25.
12, 25.
Yeah. Remote, so delivery free, so.
What I'm going to do, I'm going to mute everyone, and Dr. Ashley and Dr. Azie, please unmute yourselves. Are we good? Welcome, Dr. Azie. Dr. Azie, please unmute yourself. Dr. Ashley, please unmute yourself. And we mute every other person on this platform. Is that it? Hi, everyone.
Hi.
That's the class. All right, I'm so excited. Welcome on board, everyone. This is the maiden edition of Break the Silence, Break the Stigma. We've been talking about this a long time, and I want to welcome you all. I'm going to share my screen to start with. Okay. All right. I hope you guys can see my screen. Okay. According to the World Health Organization, 1 in 4 people will experience a mental health condition at some point in their lives. An impact that has compounded significantly with the COVID-19 pandemic now affecting millions. Mental health is one of the most neglected areas of public health. Close to 1 billion people are living with mental health disorder. 3 million people die every year from the harmful use of alcohol, and 1 person dies every 40 seconds by suicide. And now, billions of people around the world have been affected by the COVID-19 pandemic, which is having a further impact on people's mental health. Yet, relatively few people around the world have access to quality mental health services. In low and middle income countries, more than 75% of people with mental health, neurological, and substance use disorders receive no treatment for their condition at all. Furthermore, stigma, discrimination, punitive legislation, and human rights abuses are still widespread. The limited access to quality, affordable mental health care in the world before the pandemic, and particularly in humanitarian emergencies and conflict settings, has been further diminished due to COVID-19, as the pandemic has disrupted health services around the world. It is really sad to say that we are already seeing the consequences of the COVID-19 pandemic on people's mental well-being. All right, welcome on board, everyone. My name is Oluwatosin Olakoyin. People call me Mother Drum of Africa. I'm a singer-songwriter, a substance abuse counselor, a mental health professional. I have with me on the program today, I'm so excited. Also joining me on the program today is Dr. Ashley Doucette. I hope I pronounced that. She's a New Orleans native and the CEO director of Doucette Consultant LLC, a psychiatric consultation organization providing treatment, community education, and mental health advocacy. Welcome, Dr. Ashley.
Thank you so much for inviting me. I'm really excited to be here, so thank you.
Right. Also joining us on the program today is Dr. Azie. I used to call him Aza. He said he's not Aza, he's Azie. Dr. Azie is a first-generation American who grew up in Trinidad. He's a psychiatrist and a musician, Dr. Azier is the co-founder of Renaissance Entertainment LLC, a company that operates at the intersection of music, science, and community building to promote a culture of wellness. Welcome on board, Dr. Azier.
Yeah, thank you for having me. I'm excited to be here and have this conversation.
All right, you want to drop us a little line? Let's start with that on a lighter note.
I got to get warmed up. I got to get my vocal cords warmed up.
Okay, warm it up because we would like to hear your voice, Dr. Azier, as time goes on. All right, Break the Silence, Break the Stigma roundtable discussion will be taking place every last Sunday of the month, and it's going to be via Zoom, and we will share on YouTube and our Facebook. And if you're not yet a friend of our foundation on Facebook, please follow us on Mother Drum HAF, and you would have a lot of information. Also, you can visit our website, www.motherdrumhaf.org. We have a lot of resources there for everyone. I'm telling you, for everyone. And prominent personnel in the arts and healthcare system will be invited, and we'll be discussing a lot of beneficial societal benefits of early prevention of mental and substance use disorders, the available treatments, and also to use the arts to spread a message of hope to families and individuals affected by addiction and mental health. I hope you're all excited about that. Okay, let's start. Mental health, addiction. What is it? Who gets it? Dr. Ashley, let's start with you, please.
Okay, so the first question, I guess, to do this in two pieces. So what is mental health? And I get that question a lot. And this is my response. Everyone has mental health, irregardless if they have a mental illness. So I'll say that again. Everyone has mental health, irregardless if you have a mental illness or condition. So there's three components of health. You've got physical health, spiritual health, and emotional/mental health. And if any one of those three components are off balance, the total self is going to be off balanced. So if physically you have something going on, it's going to impact your emotions and your spiritual self, how you're able, the self, the soul, how you're able to deal with the world. And then vice versa, and amongst the three. So the way I try to explain things to people, the brain is like a computer. And sometimes there's certain parts of the computer that may not function as it should, or as we are typically used to seeing it function. And therefore, that's what your chemical imbalances are. That's where if you have certain strokes in different parts of the brain, that it can produce different symptoms, different personalities, different sensory losses. So I try to, when I'm speaking with my patients, as they're trying to understand their own disease process, that yes, I'm a psychiatrist and not a neurologist, meaning I study the mind and not the brain, but the brain is an organ. So your brain, my brain, Dr. Azier's brain, all of us, did I say that right?
Yes.
No, yeah, I did. Okay, great. Okay, Dr. Azier's brain, all of our brain anatomically looks the same. Frontal lobes in front for personality, occipitals in the back for visual, I've got our brain stems, but we're all different people. Okay. That's where the brain comes in. And I can't study the brain without studying the mind. So there's the connection. And that's what connects it all. And I guess so what happens if something's wrong with the computer? And that's where with certain disease processes, we can go back to the brain and kind of say, hey, this area of the computer needs a reboot. Or this area of the computer is firing off hallucinations. We'll go there later. It's saying a stimulus is there when it's just not there. So in summary, again, we all have a brain. We all have a mind. It's important for us to manage our stress because we all have stress. It's important that we learn healthy mechanisms, healthy ways to cope with our stress. Because if we do not pay attention to our mental wellness, our mental health, it will lead to deterioration, which then is going to lead us to mental illness and mental conditions, which tying that to addiction. And as you and I spoke, I want to spend some time when we do deep into addiction of the difference between dependency and addiction, because there is a difference. But when we get to the addiction part as a whole, we have not been taught good, positive coping skills. So a lot of what stems from addiction is self-medicating. I'm in pain. I got to get out this pain. I can't sit in this pain. This thing is not going to take the pain away, but it will allow me not to feel it for a while.
Okay.
And so that's one component. We've got some other components as well that as we talk more, we can certainly get into. But that is my way of looking at this world, this planet of mental health.
Awesome. Awesome. That's really beautiful. I love the way you really explained that. And before I call Dr. Ezie to come into that particular question again, I would like to tell everyone on this platform, please leave your name and let us know where you are reaching out for. If you are in Africa, Nigeria, let us know. Let's give a shout out to you. All right, Dr. Ezie, I'm going to ask you the same question. I know Dr. Ashley said everyone has a mental health, even if they don't have mental illness. What is addiction and how can you define mental health, Dr. Ezie?
Yeah, no, thank you. And Dr. Ashley did such a beautiful, comprehensive job, I think, in her definition. It's hard for me to really add anything to it. But I think just to kind of reiterate some of the important things is like understanding that we have these different planes of being. And she mentioned like the physical, the emotional, mental, the spiritual, and really understanding how those things tie together to produce wellness, or inhibit wellness, I think is really important. And she talked about the brain and the ways in which, it can contribute to, different ways of experiencing the world, but also our environments, what kind of environments we're in can have a lot to do with how that brain is shaped and sort of what kinds of behaviors are promoted and what kinds aren't. I think addiction, again, I think Dr. Ashley did such a beautiful job in describing it. It's really that we have these different ways of trying to deal with pain, and certain substances actually have a way of hacking into the biology of the brain. So the brain has this native reward system, right? Things like food, sex, social behavior, all those things are rewarding to us because there's this thing in the brain that says, hey, look, that was good. Keep doing that, just like there's a thing in the brain that says, hey, that was bad. That hurt. Don't do that anymore. And in addiction, basically, you have these substances that hack that system so that now this thing becomes the most rewarding thing. And it's the thing that your brain is now driving all your behavior towards. And all of the things that normally are rewarding, like food, sex, all these other things, start to lose their value in comparison. And then when it really starts to get into high gear, normally your brain will say, hey, this thing is hurtful or these things are negative, I should stop doing them. But when that substance, whatever it is, has hacked into that brain reward system, those things stop mattering as much as well. And so, I think it's one of the reasons why addiction is such a big public health concern is because in a sense, we're all at risk because we all do have pain and we could all be in situations in which, we're not able to cope with it in other ways. And so I think we're now finding out as well that, there are some like genetics that are involved. Like if you're coming from a family that has, a history of some kind of substance like alcohol, then you're at further risk, of having that. So, even in the larger context of knowing like who your family is, what kind of things run in your family, all those things can tie into addiction. But I'm sure we'll continue to kind of
Awesome. That is really beautiful. Let me quickly say, drop this disclaimer out here, that the information that we share on this platform is not a substitute for a professional medical services, diagnosis, or treatment. It is basically for educational and awareness purposes. And we advise people seek medical advice from a qualified healthcare provider if they have any questions about their addiction or mental health challenges. I just want to quickly drop that. That's really beautiful. Okay, Dr. Ashley, I know you said there's a difference between mental health and mental illness. It took me a while before I could know the difference. And I know there are a lot of people out there who does not even know the difference between mental health and mental health conditions or challenges. How do we know the difference, and what is the difference between mental health and mental health challenges? Dr.
Okay.
Ashley.
So I'm going to take your question and kind of add it with another question I commonly get, which I think overlies it. So here's like a tangible example I get often. Well, how do I know if I'm depressed? Or how do I know if this is just not, normal mood changes, that everybody's not always going to be happy? How do I know I'm just not having the blues, especially around the holidays? Perfect example to talk about. And I think Dr. Azier will say, we get very busy around the holidays. And so is it just the holiday blues? Is it just today just isn't gonna be a fantastic day, which is completely normal? When does it go from normal to I need to seek help and talk to someone about this? So when it starts to negatively impact important areas of your life, and Dr. Azier kind of started hitting on that. Things that were important, priorities that were important, become not important. So things such as spending time with family and friends, that becomes less, and not just less important. It's a sign of things are becoming clinically relevant at this point. Isolative, withdrawn behavior. You don't have to be crying or actually feel depressed to be depressed. So now let's get to the deep criteria of it, okay? So there's a book so that when I'm looking at someone, and then in Dr. Azier, I know you're from Trinidad, but I don't know where you're stationed now.
Right now I'm in New Haven.
Okay, New Haven. So I'm in New Orleans, Dr. Azier is in New Haven. We want to be able, if we see someone, be able to describe what we see to each other. Now, any other field of medicine, we can do a lab, draw some blood, take a test, do an x-ray, take a picture, and boom, we know this is what you have. Mental illness doesn't work that way. We're going by subjective, sometimes objective, but mostly per mouth, what someone else has seen, said, and experienced criteria. So all of this is a spectrum, okay? Mood disorders, depression, anxiety, it's all a spectrum. But we kind of make these little categories so that what I see and what Dr. Azier sees, we can describe what we're seeing, all right? So we've got major depressive disorder, kind of like your regular depression. We've got your bipolar disorders, where people go through really highs and then really lows. Well, if I see that, that's a different kind of depression. So that's why I've got the label of that. So when Dr. Azier reads that, he knows, okay, she must have saw some highs and some lows in this. Or postpartum depression, all right, clearly following a baby. Premenstrual disorder, before your menstrual cycle, more severe than PMS. So again, these labels are the categories. Okay, now kind of getting back to your question. So when does it become bad? So I told you, you don't have to feel depressed. You can just not like or not get pleasure out of things that you used to. You used to like to read. You don't like to read anymore. It doesn't do it for you. You used to love to exercise. You used to love to cook. You used to love socializing. None of that does it for you anymore. The things that previously brought you pleasure, they don't bring you pleasure anymore. The fancy word for that is anhedonia. Okay?
What?
So you can feel depressed, or you could just kind of feel flat. Just doesn't do it for you. And then there's some other criteria we're looking for. We're looking for changes of sleep, changes in appetite, cognitive changes, changes in concentration and attention, changes in memory, changes in sex drive. So it's encompassing a cluster of symptoms, and then that's affecting work life, home life, and even if you don't have a job, but you're at home, it's affecting your relationship with yourself. And when those negative impacts tend to last more than a 2-week span, that's when you need to go and talk to someone.
2 weeks?
That's the by definition. Okay. There's always exception to the rules. If you have thoughts like you want to hurt yourself, I don't care what the time has been. Go see somebody. You don't need to wait for 2 weeks for that. But in general, you can have a bad week. That's okay. But when things tend to last and then start to impact you at home, you at work, you with friends, you with family, you with children, you with yourself. I can't sit still with myself and even enjoy a book, enjoy a movie. I just don't feel like myself. I may not feel like crying. I could feel irritable. I can feel all kinds of mood, but I just don't feel like myself.
That's beautiful, Dr. Ashley. Dr. Ashley. Okay, that's so nice. Dr. Aza, I would like to ask AZA. It's easier for me to pronounce it like that. But Dr. AZA, I'm going to ask you. I know when I read the opening remark, we saw how significantly the COVID-19 has impacted the healthcare sector. What can you tell us as COVID-19, how can we, I don't even know how to put it, because it definitely, the pandemic affected everyone. Do you see a change in the increase in the way this pandemic affected people mentally, physically, and spiritually?
Yeah, I mean, definitely. So, I mean, historically, we know that there's data that suggests that anytime there's some big event, like a traumatic event, like a pandemic or a natural disaster, mental health conditions in that population increase in the wake of it. So that's already a given, and we knew that would happen here. The early data out of China actually shows that there was an increase in mental health conditions in their population and previous pandemics. So I think we were prepared for that. I think in the US, it's particularly interesting because we see that people of African descent are being disproportionately affected by COVID-19, both from a standpoint of sort of overall health, but then also particularly when it comes to mental health. And I think there are a number of reasons for that. Structural racism and sort of the resulting stress of that leads us as a people generally to have a greater comorbidities of stress-related disorders. Right. And so when you hear them talking about COVID-19, they say, oh, the reason that, we have these disparities are because people have pre-existing conditions. When you look at what those pre-existing conditions are, many of them are stress-related or are exacerbated by stress, right? So people of African descent have racial trauma and stress as one thing. Then on top of that, we know that sort of socioeconomically, that's another stressor that is disproportionate for our people. And then on top of all of that, isolation, social isolation is in and of itself a risk factor for mental health. And you can do this even in mouse models. You can show that just having a mouse alone for 24 hours leads to like these dramatic changes in the brain. So all of those things together has definitely, impacted people in a significant way. And we do see a lot of people coming into the hospital who were actually doing pretty well up until COVID-19. And especially this becomes true for people with addiction because many of them rely so much on social support as a part of the strategy of coping with addiction. So, I remember seeing a guy, doing a home visit, and he couldn't go to AA meetings. And for him, that was like a huge part of, maintaining his wellness and abstaining. And so he was very, very worried at the beginning of COVID-19 because he could kind of feel the impact of not being able to go to those meetings. So yeah, that's definitely something that we've seen.
Awesome. Wow, this is really sad. Also, I would like to ask this question. Is there a difference between addiction and substance use disorder? Dr. Azier.
Yeah, I mean, I think a lot of it is sort of terminology in terms of addiction historically really has been a very pejorative word that has like a negative connotation and also puts a lot of blame and sort of moral implications on the person. And so I think, again, and we saw this a lot, again, when we talk about sort of how descent plays into all of this, we saw that with people of African descent during the crack cocaine epidemic, right, there was a lot of moral judgment and placed around this issue of addiction. Whereas sort of as of late, in now the opioid epidemic, which has a different demographic, right, more people of European descent, the whole framing of this now has been transitioned to completely a health condition, right? And so I'll be interested to hear your thoughts, Dr. Ashley, but in my opinion, that distinction, when talking about the actual functional problems that the person is having, isn't really that much of a difference. But I think substance use disorder is a way of sort of reframing how we're thinking about what the person's struggling with.
Dr.
I
Ashley, you want
totally
to say
agree.
something?
I totally agree with what you said. And I guess as you were hinting to it, I was trying to hold my emotions back, but my face never hides my emotions well. So I'm in complete agreement. I'm actually an opiate dependency treatment provider. So using the MAT, Suboxone, methadone, etc. But to answer specifically, so yes, we have substance use disorder, and now with the new DSM, they've actually kind of caveated that out a little bit away from addiction. And so it's just use, mild, moderate, severe. People do, use substances recreationally, and should you come across run into a hospital or a physician and you're screened, well, that could have just been a recreational use. So when we go into more of the term addiction, it used to hold, again, negative consequences, as well as symptoms of like withdrawals. That used to be kind of like the big hit, that if you could withdraw from something, then you were addicted to it. And that's where I want to bring in just the topic of dependency and dependency pain, okay? Because here's the deal, in talking about the opiate epidemic, and I'm going to make it relevant in terms of culturally in a minute. If you were sick and you go to the doctor, any person, I'm not even going to tell you a cultural background or a racial background. Person is sick, I'm in pain, I broke my clavicle, it's in pain, I'm not healed. Here, you're the doctor, I come to you, Dr. AZA, and then you give me a prescription for opiates. And then I come back to you, my pain still isn't there. And then you give me the prescription for the pain pill. Well, I would not have taken the medicine unless he would have given it to me. So now that he's not prescribing them anymore, whatever, I need my medicine. At this point, am I addicted or am I dependent?
I like that, Kristen.
You are physiologically dependent, just like someone who has diabetes is physiologically dependent on that insulin. Are they addicted to the insulin? Will they die if they don't get the insulin? Mm-hmm. Will somebody feel like they're going to die if they don't get the opiate? Mm-hmm. Is that symptoms of withdrawal? Mm-hmm. But we don't see that. We don't see that for our blood pressure medicines. We don't see that for our insulin medicine. So, and I'm not saying pain medicine should be distributed as such. It's just, what are we putting on the responsibility of the patient? And then it takes on this ownership that it's a fault. It's your fault, negative connotation, a bad person. And then let's parallel, and we're not the only people saying this. The only other time we've seen substance abuse of this magnitude is during the crack epidemic, which was mostly affecting African-American communities or people of color, okay? Now let's take a snapshot of where we are with opiate dependency right now.
Okay.
We've got treatment programs out the woo-ha, right? You can be diverted from jail and go to the hospital with a treatment program. So you got arrested doing something you had absolutely no business doing, intoxicated, but you don't get to get a record, because if you're on opiates, you get to say that and then you get to go to a treatment facility. Did they do that with people of color during the crack epidemic? Or were we just getting charges and being thrown in jail? And where was the treatment? Where was the grant money? Where was the federal funding? There was some federal funding, but it wasn't for treatment. That's a different topic. So that being said, addictionology as a whole is very important. We, as a world, we have not learned proper coping skills. And whether it starts off recreationally or it starts off via prescription from a provider, if it gets to a point where it's out of control and you need help, it doesn't matter. And so it's important to consider it, but what I tell people, don't worry about the label. I don't know if you're dependent, addicted, whatever, just come and get the help. We'll work on all that stuff later. just come in and let's just get you started.
All right. That's beautiful. All right, Dr. Ashley, thank you for that contribution. Let me quickly say hello to everyone here. We have Ude Arisin. We have Chinaza from Nigeria, Michelle from Nigeria. We have Vivian from Toronto. Thank you for joining us. And please leave your questions. And after this session, we would ask our psychiatrist all the questions that you may want to ask them. We have Ifeori Molade from Miami, Florida. Welcome on board. Okay, that is nice. Thank you so much, everyone, for joining us today. Okay, Dr. Aza, I want to ask you this. Now, let's talk about stigma and wellness. How is, in fact, is there stigma? When we talk about addiction, is addiction stigmatized? Are people that are addicted to a particular substance or whatever it is, are they stigmatized? How can we bridge this, the gap between stigma and wellness, even if there's stigma at all? Dr. Aza.
I mean, I think it's very clear that there's stigma. I think across just you know, substance use in general, and I think you know, Dr. Ashley mentioned, you know, even historically how that, you know, that came to be. When we think about cannabis, you know, why did it become illegal, right? And how were the people from the Latinx population being vilified as a part of making cannabis illegal. And so I think there is a lot of stigma still, and we see it actually in healthcare still, when, you know, people who are struggling with substance use come into the hospital in the emergency room or are on inpatient units. You know, there's that stigma. How do we bridge the gap? I think the realest and truest answer is like teaching people how to view humans as humans, right? But that's kind of, it's too simplistic and too lofty at the same time, in a sense, because that really would be the solution, like understanding that we share this common human experience, and sort of the things that we experience, the genetic material that we inherit, and a lot of things that are outside of our control fundamentally shape what we're going to experience and how it then impacts our ability to function and our mental health. But I think sort of a first step towards that is just education and awareness, which is, you know, I think part of what this is, and speaking out, people who have struggled with substance use. And I think another thing that I didn't mention when it comes to addiction is that addiction is also something that can exist outside of substance use, right? So you can be addicted to things that have nothing to do with a particular substance. Right? And so that is another point that, you know, I wanted to make in terms of substance abuse disorder versus, you know, addiction. And so, yeah, I think that part of it is always going to be education and awareness, teaching the person about, and teaching the society and culture about like how these things develop, and then putting the kinds of efforts that are being put now into substance use treatment. The proactive approach would be to put that sort of funding into building the sort of social structures that don't cause addiction. You know what I mean? And a lot of like people like Carl Hart at Columbia have done a lot of work showing like how people's environment and their socioeconomic status and race and all those things play into who can use a substance and then become, you know, develop a substance use disorder and who doesn't. So I think that's another kind of way to think more proactively, is like, how do we build the kind of social structures that actually that make addiction less likely? But I think it starts with education and awareness.
Education. Thank you so much, Dr. Aza. Dr. Ashley, you want to jump on that, please?
Totally agree with Dr. Aza. I've got my master's in public health from Tulane as well. And that was where I concentrated on community and maternal health and preventative measures. We never do preventative medicine. We don't do the stuff that would keep us from getting sick. And I think what ties, and I don't want to get us too much into that conversation, but just what's going on here in the States a little bit. And as far as like with defunding the police, which I'm a Cox retired police officer's daughter, my family from New Orleans. I mean, I come from a huge family of police officers, so nothing but respect. However, stuff has to change around here. And that being said, part of that defunding of the police, which and what's going on in the civil unrest here, it's not saying that we want to totally abolish the police department, but it's taking those funds and bloated budgets and putting it to mental health facilities, treatment facilities, counseling facilities, having a physician, if there's a call out to the house, having a mental health professional or someone from EMS on call when they're making these calls, such as the Breonna Taylor call, having someone there that can prevent something from happening. So that it's really important that if we can catch things early, if we can talk about things early, and part of the stigma has been generational. Let's just be clear. Our parents didn't believe in this, so they didn't talk to us about it. And Dr. Azier, I don't know if you got the same kickback even within the medical community or with your family. I remember when I graduated from medical school and I told my mom I was going to be a psychiatrist. She's like, what? She's like, well, what'd you go to med school for all that for? And I'm like, Mom, because it's medicine. And she's just like, I just don't see it. And now it's like, oh, see. So here's the guy. So I can see why you see it. So there was stigma within the medical community. There was stigma within our communities. And then there's stigma generationally, racially. You don't go talk to no, let's just put it what it is. You don't go talk to no rich white man about your problem. That's rich people, that's what they do. You go talk to the Lord. Religious, the church kept us out of the facility. And now we're seeing the church is stepping up and saying, yes, when you come to me with your breast cancer, we put the hands on, we believe in healing, we speak it, we believe it, but we still tell you, go do your chemo. Same thing when you come to me telling me you are depressed. Yes, I'm going to pray for you. Yes, we're going to believe in your healing, but I need you to call somebody and go get some help on that too. And what I tell my patients, I'm just a tool. God's going to heal you. I'm going to treat you. But I'm just a tool he uses, just like he uses the chemo, just like he uses the insulin. That's what Dr. Azier and I are. We're just the tools. So when we break that and we talk about education and when we get into the communities and let them know, hey, that we can do better with lifting the stigma within our own community, not just what everybody else puts on us, but we can do better. When that lifts, then we will see us welcoming counselors and social workers and people who want to help us into our communities. We're afraid. I get it. I get we've got fears, we've got concerns, we've got walls up. But that's why Dr. Azier and I are here. Like, we had to get in the system to try and change it. So now we're in it. And that's what we're really trying to do from within. Tell you, hey, I know you're scared, but this is where it starts. To start it unraveling. Ask us the questions, which, like you said, please drop us questions, everyone listening, because we'll go back. And we've got ideas of topics that we want to talk about. But if there's ways that we can help you all from all over the world, we would love to do that. So please help us do that.
Help us to help you. You said that, right?
Help us to help you.
Help us to help you. That is so brilliant. I was going to say, you keep mentioning just like maybe if somebody has a cancer. Do you think mental health is being seen as any other medical health issues out there? Do you think that people will look at a depressed person as equal as someone who has a blood pressure?
Dr. Azier, do you want to go first?
I can take it. I don't think that, so I think part of it, I don't think people think that way yet. I think part of it is that we know a lot more about the biology and sort of material aspect of a lot of other illnesses than we do about sort of mental health. And so the brain in a lot of ways is still a mystery. And I did my PhD in neuroscience. I still have no idea what the brain is doing, So I think that's a part of the reason there's so much mystery there that it's hard for people to view it in the same way as they view other disorders. I do think that there is an element of mental health and how we experience it that isn't the same as like a liver illness. Even though if I have something wrong with my liver, it's also going to affect my mental health. right?
Okay.
So everything is connected. And I think the more that we view our health in that way, that's like very holistic. Like if I have diabetes, that affects how I think, it affects how I feel, it affects it will affect my mood, it'll affect how I think, right? These things are, if I exercise, that actually helps my mood, right? It helps me to feel like I have more energy. If I eat certain foods, that actually helps my mood. So all of these things really work together, and we have to think of them holistically. But I think just from a medical standpoint, we still don't have enough information about the material aspects of mental disorders, or for most people to view them in the same way as they do like
Yeah.
cancer
Well,
or diabetes.
thank you so much, Dr. Aza. I look at the way people stigmatize mental health conditions and the way they talk about every other illnesses. As far as I'm concerned, I think the way to, minimize the stigma, first of all, is to change the conversation about addiction and mental health conditions. People should see any other person that have depression, bipolar disorder, they should be able to speak out. I'm like, I think I have bipolar disorder. People should not be ashamed of talking about these things. But the stigma that has been associated with mental health is keeping a lot of people from expressing themselves. They hold back. Unlike if someone has a blood pressure, like I have high blood pressure, they take their pills anyway. Nobody wants to say, oh, I have substance use disorder, and they're popping their pills out there. People are so ashamed. I know education can work on this, as you all said. What other ways can we minimize this stigma? Because our people need to speak out and seek help. Dr. Ashley.
So again, the churches are a huge place within our own communities. That's where we've gone historically for gathering, for information, for feeling and sense of community. So that's a central component in addition to the support of church. You do need that. And there's a lot of, again, there's this, I would say, a new wave over the last 10 to 15 years where I believe that mental illness is starting to directly touch some of these religious leaders within their own home. I can say personally, my pastor, Pastor Eileen Lumar Johnson, unfortunately, her son is severely autistic and has terrible seizures. And she realized with her spiritual journey that she wasn't gonna pray that away. However, through treatment, through research, and being very engaged with her doctor, her son is doing fantastic. Does he still have seizures? Absolutely. Sometimes in church, we'll lay hands on him. But that boy, they said he would never speak. He can speak. He can recite verses better than I can. So we need their support. I'm sorry, that's my dog. Baby horse, stop. We need their support because that is such a central place of support within our communities. The second part to that is we have to be the generation of transparency. We have got to, those who people would look and say, I would never, not that person. We've got to change that perception. We've got to change that I hate that word, crazy. We got to do something with that word. Now I can name you somebody who's crazy, but like I say, I don't treat crazy people. I don't know about you, Dr. Aza, but I didn't go to medical school to treat crazy people. Now I know some in my television screen right now. Nevertheless, that's not what what our verbiage needs to be. Our language needs to change. Awesome. Language is important. Words are important. So our language needs to change. And then we need to, and this is where I have hope, because people don't always have to understand it to accept it. And that sounds a little funny. Piggybacking off what Dr. Aza was saying, there's no tangible test that says, here's this test, here's this lab, here's this picture of this organ that says you are depressed. Because there's nothing tangible somebody can put their hands on for anxiety or depression or bipolar. That's what makes it like unreal. So the more, again, learning, we will learn through that. But COVID, let's think about it. COVID has given everyone a little bit of taste of how close you could be. The isolation, the withdrawal. the fear of the unknown. People who jobs were guaranteed. Nothing's a guarantee right now. Nothing. We're all walking day by day, all together. And for those who realize we were all connected anyway, it's not that hard of a stretch. But for some of us who were looking at mankind and looking at our neighbors that, well, that's so different than me. Now we realize, oh, your home can be all right, but you can have all the hand sanitizer in your home, but you got to step outside. So if you don't take care of your community and your community is sick, what is the hope for you? So that gave us a sense of what others go through. It gave us a very small, very, very small taste of what solitary confinement can look like, feel like. And so even if people can't say, oh, I felt depressed during COVID, or I felt anxious, because they can't always put the word to it. They know they didn't feel right. They know they don't like the way they feel during all this COVID stuff. So I think now is the time that perhaps someone who couldn't have sympathy or couldn't understand it could say, okay, I don't understand it all, but I can see how something up here, when I didn't feel right up here, it affected everything or what I did.
Everything. Awesome. Thank you so much. I see your questions. I'm going to jump on them very soon. Before I go to the question and answer segment, I will quickly mention this because while we were doing the opening, he says relatively few people around the world have access to quality mental health services. Now, it is one thing to know you have a problem. It is one thing to want to seek help and the help is relatively available. How can people get help even when they even break that aspect of stigma? Okay, I have this problem. I'm not ashamed anymore. I need help. How can people assess this? How can people reach out and get help? Dr. Ezi, I'm going to start with you briefly.
Yeah, I mean, I think the first step, I think, is talking to someone who you trust, right? So if you're someone who has never gone to see like a therapist or a psychiatrist or something like that, that could be like an intimidating first step. Like I remember when I was in med school was the first time I went to see a psychiatrist. And I remember feeling like, okay, once I go, does that mean now that like, right? And I was a med student, right? So like obviously, but that's how sort of conditioned we are to view mental health. Even if as a provider, there are many providers that feel weird about starting therapy. Like I'm in therapy now as well, and so I think sometimes just talking to someone who you really trust and being like, hey, like I'm really struggling with this. That in and of itself, just admitting to struggling with something can kind of take some of the tension away and relieve some of the burden. A lot of places have emergency hotlines that you can use, and they're very effective at getting you connected to help, especially if it's sort of an emergency situation. If you feel like you're unsafe, you can always go to the emergency room, and you can be assessed there. Yeah, great. Yep, this is definitely an example. Like exactly. These hotlines are good. And depending on where you live, there, I think, and the reason kind of I'm struggling is because there has been a lot of issues with access to the mental health care system, especially for people of color. And so sometimes it's very difficult to get from like a primary care physician to get an appointment with a therapist or psychiatrist. And so I think part of me mentioning that is like, don't become discouraged or frustrated if it doesn't happen right away. Like this, it is a broken system. It's one that Dr. Ashley and myself are, I think, working within to try to fix. But it wasn't designed to be most accessible for you. But some of those things that I mentioned, I think, are good ways to kind of get started. One other kind of thing I'll mention is that actually we're currently doing a study that uses music and mindfulness as a form of stress management for people of African descent. And so that's another mindfulness and sort of having creative outlets. All of those things are also things that you can plug into that help to take the first steps towards mental health.
Thank you so much, Dr. AZA. I know we don't have all the time, and like I said, it's still going to be a discussion that is going to continue over the time. It's going to be every last Sunday of the month. Let's quickly go to the question and answer segment. We have this person says, let me just not mention the name. He says, how can you help a family that displays schizophrenic symptoms but thinks is a spiritual attack? Dr. Ashley.
Oh boy. So I guess the first thing would be to talk to that person and try and express your concerns and try to come to some type of I guess common grounds or basis that, hey, let's just go check it out. Let's go have someone check things out. If it is what you say that it's nothing, then it'll be nothing. That's probably wishful thinking a little bit on my end. In reality, there usually is a lot of resistance when it comes to family members and seeking help. I will say this, you always want to give the person the respect to have the conversation with them. No matter how lucid you think they may be, they do deserve that respect. However, if they're not cognitively in a place where they can receive this help, there are extreme measures to go, which would be to get your psychiatric corner, wherever you're located, involved. And what they do is, if someone is a danger to themselves, a danger to someone else, or they can't take care of themselves, meaning they'll go days or weeks without their medicine, they won't eat, they won't bathe, things like that, you can have someone evaluated for 72 hours. And so, or up to 72 hours. And so for any family member, that would be the best advice. I would say, let the professionals make that call. Family can often hold grudges. So what I suggest people do your best to present the help for them, present information, get those professionals involved, and then back out. And let those professionals do what we need to do.
And still respect their space. I like that. Thank you, Dr. Ashley. This one says, this has been a truly inspiring session. I love how Dr. Ashley explained the role of church in breaking the stigma. I also love how Dr. Azie highlighted the effect of mental health during this pandemic. I'm taking notes and my notes is almost full. All right, thank you so much for that feedback. Chinaza said, I'll definitely lend your book after this. All right, this is beautiful. Okay, so they said, no matter what problem you're dealing with, whether or not you are thinking about suicide, if you need someone to lean on for emotional support, please call the National Suicide Prevention Lifeline. It is 1-800-273-TALK, talk, or you say 1-800-237-8255. All right, thank you so much for leaving that out there. Okay, well, before we round up, we talk about, I would want us to touch suicide, the effect of addiction and mental health on suicide rate. If we can quickly touch on that before we round up the program. Anybody can. Dr. Azie, Dr. Ashley.
I mean, I think suicide is in psychiatry, one of the things that is the highest risk thing that we, one of the most emergent things that we deal with. And so I think for, if you or anyone else are thinking about hurting yourself or are having those sorts of thoughts, or you're actively, coming up with a plan, then that is the time to seek help. If you know that someone has those plans, then I think, it is the right thing to do, to seek help and to kind of curb that emergency. I think we see that the rates of suicide are also, have been increasing within our population. And so, I think, Dr. Ashley kind of hit on it earlier where she said, everyone has pain in some way. And the kinds of experiences that we have growing up, the kinds of things we're taught, how we're either taught or not taught to deal with emotional trauma and stress, can lead us to a place of, extreme pain where like we don't want to be here anymore, and I know I personally have had, people that I know that have struggled with suicide, have attempted suicide. And so I think the important thing to do is, to be there for people you know, and to always, you know, when you feel like you're out of your depth, seek help from a professional, because that's, you know, that's why they're there.
Wonderful. Thank you so much, Dr. AZA. Dr. Ashley, you want to run up on that, please, quickly?
I totally agree. Just a few things, some warning signs, I guess, to look out for. If your loved one expresses like giving away their prized possessions or things that they hold valuable, if they start to withdraw, become more isolative, increase substance use and abuse, which sometimes we're not sure if certain overdoses are true suicides or accidental suicides. But again, if you know that loved one who has been struggling, also struggles with a substance abuse or alcohol problem, that would be, you know, something to look out for. Increased use. Weapons in the home. If you suspect someone or just have a bad feeling, it's okay to ask, do you have any weapons in this house? It's okay to say, give me those weapons to get them out this house so you feel better. Have the conversation. It may, like Dr. Azier said, you know, access to good care, it is difficult. However, in an emergency situation, safety is primary. Awesome. And it may take a little time to get that therapist that you really feel comfortable with. That may take you some time. But to get immediate help, if you're having thoughts like you want to hurt yourself or somebody else, ER, hospital, calling 911, using the telephone numbers and text lines that we supply from different organizations, they are on it and they will help you now. So don't look for a therapist necessarily in the ER, but look for safety. And I love what Dr. Azier said. The first step, just talk to someone about how you're feeling. It doesn't need to be a healthcare professional. It could be the person sitting next to you on the couch. Yeah. It could be a loved one, whomever you feel that you trust, and tag someone and say, I don't know what this process is like. I'm nervous about this process, but I know I need help. And will you help walk with me through this?
Thank you so much, Dr. Ashley. I know we have a lot to talk about. Next month is going to be another time to talk more on another topic. And now you know that you can ask questions, compile your questions, and next month we will talk about this. Please reach out for help if you ever need help. Do not be ashamed to seek help. This is the National Suicide Prevention Lifeline. Please make use of all those help that are around you. National Suicide Prevention Lifeline is 1-800-273. National Helpline is 1-800-662-HELP. And also, if you're in crisis, please text SHARE to 741-741 if you're in US or Canada. And if you're in UK, please text 85258. Again, it's 85258. And if you're in Ireland, please text 50808. And crisis text line is for any crisis whatsoever. And you're going to talk with trained crisis counselor. This is where we're going to draw the curtain this month, and we look forward to seeing you next month. You guys should have a good one, and together we can break the silence to break the stigma. Have a good one.
Thanks.
Bye, everyone.